So I thank Dr. Naresh and the organizers for giving me an opportunity to be part of this session. So I'll be talking about vitreous and how we can, basically the anatomy of the vitreous, and then various ways in which we get an opportunity to treat vitreomacular diseases without going for vitrectomy if there are any options. We have agents now available, but how do they act? What are the indications? I'll be covering these aspects. So it's very important to know the anatomy and physiology of the vitreous before we can contribute to the evolution of treatment of vitreous pathologies. So vitreous, as we know, is mainly water, but most importantly it has collagen which you can act on. It also has hyaluronic acid and very importantly laminin and fibronectin. These are two common components at the vitreoretinal interface. So if you can imagine this, that if you have an enzyme or any treatment which works only on collagen, like collagenase, then you may not be able to tackle the VR interface problems because we are not tackling laminin and fibronectin. Similarly, if you have an agent which acts only on laminin and fibronectin, it will not be able to act at the collagen level. So any vitreous hemorrhage or vitreous opacity cannot be tackled by an enzyme which acts only on laminin and fibronectin. So you need an enzyme or an agent which acts at multiple levels. So the adult human vitreous contains very fine parallel fibrils, and that's how you maintain the optical clarity of the vitreous. Vitreous is very transparent. And one important question which people always have is, what is the function of vitreous? I mean, in the anterior chamber you have aqueous. Why do you need a jelly in the vitreous? And some people say it's there to give shape to the eye. If it is true, then we all VR surgeons should be causing phthisis to all patients after vitrectomy. So it's probably a function which not many people have understood. What is the function of vitreous? Why is it so complicated in terms of management? If it had been aqueous, it would have been, our vitreous surgery would have been just 1 minute, lavage for every patient for vitreous hemorrhage. So it's so complex. So the function actually now we are trying to realize is that vitreous, the arrangement, it sequesters oxygen and it prevents the oxygen from diffusing into the lens. So that's why after vitrectomy you tend to get the nuclear sclerosis, because oxygen starts diffusing from the retina towards the lens. The oxygen concentration behind the lens is very less in a normal eye because the vitreous gel, it does not allow the oxygen to diffuse. So even in older patients, when the vitreous starts liquefying, you say nuclear sclerosis is developing, that means the vitreous is becoming liquefied and it is not able to trap the oxygen. That's why with age also the nuclear sclerosis starts developing. So that's the function of the vitreous gel. And the collagen, it's actually mainly collagen type 2. And there is also hybrid of collagen type 5 and 11 and type 9 collagen. This is the microstructure of the vitreous fibers, and you can see there is a core made up of type 5 and 11 collagen, and type 9 collagen is on the outer aspects of this. So this work has been done to a great extent by Jerry Sebag from California. So he is one person who has to be credited for most of the work done on the physiology of vitreous. So what is anomalous PVD? Anomalous PVD is something where you have this vitreous liquefaction, but there is no separation of the hyaloid from the retina. And this is very common, especially with increasing age. You get your ideal PVD is something where the vitreous is also liquefied and there is separation of the hyaloid from the retina. That happens in many patients, but in some of the patients, when there is anomalous PVD, you can have horseshoe tears, or you can have ERM formation or macular hole formation. This is a case where you can see that there is attachment to the retina causing vitreomacular traction, and you can see there is another layer above the retina, and there is some amount of vitreoschisis also which is happening in these patients. So even vitreoschisis, where the posterior hyaloid is split into multiple layers, is also an important cause of various pathologies in the eye. Vitreomacular adhesion disorders can be divided into tractional or non-tractional, but most of our focus will be on the tractional disorders of VMT, vitreomacular adhesion, vitreopapillary traction, and macular holes. So, coming to after having looked at the various microanatomy and physiology of the vitreous, we'll come to how we can manage the vitreous, or people are trying to see vitreous in terms of pharmacological therapy rather than surgical therapy. And people have tried for the last 4 decades various agents for pharmacologic vitreolysis. We have had collagenase, hyaluronidase, dispase, and chondroitinase, and recently ocriplasmin, which is microplasmin, has been approved for use, and it is being used in some cases, at least in the US and Europe. There are different ways in which these agents can act. They can be either enzymatic or non-enzymatic. Non-enzymatic, there have not been many. Urea was the only drug which we know had gone into phase 3 trials. About 5-6 years ago, we had a trial of phase 3 trial of urea, in which many Indian centers were also participating as part of this phase 3 multi-center trial, but unfortunately it did not meet the end point. But the other ones are enzymatic, which could be either non-specific, that is, they act across different proteins, as I said, collagen, fibronectin, laminin, or they could be very enzyme substrate specific enzymes like either chondroitinase, dispase, or hyaluronidase. And hyaluronidase was the other agent which previously entered into phase 3 trial. Unfortunately, the p-value was less than 0.05 only in one trial. So all phase 3 trials have to have 2 parallel trials, and that only one of them had p-value significance, so it did not get US FDA approval. And this table is a slightly busy table, but it tells the advantages and disadvantages of the various agents, and basically disadvantage of retinal toxicity is something which we are looking for. That is mostly not there in all the agents. This is from the actual vitreous study from the early part, that you can see the hyaluronic acid here, which after the injection of vitreous, you can see that it has cleared up. And this is from the trial of vitreous 75 international units, which was injected in this patient. At day 0, there was a lot of dense vitreous hemorrhage. By day 17, the vitreous hemorrhage is cleared in this patient. Then we have ocriplasmin now, as you can see in this mouse model, where this ocriplasmin acts. It also induces the separation not just of vitreous liquefaction, it also separates out the hyaloid from the retina. So this is a very good feature of ocriplasmin, that it acts at both levels. So the clinical objective of pharmacologic vitreolysis should be that there should be vitreoretinal separation, there should be less mechanical manipulation. That is also very important, but because otherwise you can create other horseshoe tears or retinal tears. And this ocriplasmin was generated by Thrombogenics, which is a Belgian company. It is a recombinant serine protease of a very small size and has a very good tissue penetration. This shows the relationship between plasmin and ocriplasmin. Ocriplasmin is a small part of plasmin. Plasmin has been tried earlier in many cases, but was not as successful because of some toxicity. And this ocriplasmin is injected intravitreally 125 micrograms. Usually, as in the trial, they had given a single injection. So it has a dual action of both, as I said, liquefaction and separation of the hyaloid, because it also acts on the fibronectin and laminin part of the vitreoretinal interface. This is showing one example where there is hydrolysis of laminin and fibronectin, which are the glycoproteins. So apart from the liquefaction, if you have any vitreomacular adhesion, like in the trial for ocriplasmin, they had patients with vitreomacular adhesion, all patients who had less than 400 microns of macular hole. So those patients were the ideal candidates, and patients who had coexisting ERM were not good candidates for this treatment. So this MIVI Trust trial was performed in 2 parallel phase 3 trials, and then, as I said, 125 microgram was injected at baseline, and they studied the patients at 1 day, week 1, day 28, and then went on up to 6 months. And patients, as I said, with VMT, VMA, and 400 microns or less of macular hole were included. And the results were very satisfactory in patients who were treated with ochriplasmin compared with placebo. Again, here you should note that this is not sham injection. In sham injection, you don't inject anything, whereas in placebo, you inject saline inside the eye. So this study had a control of saline as per the requirement of regulatory authorities. So all saline injected patients also had some results. Like some patients had closure of macular hole, some patients had release of the vitreomacular adhesion. But overall, what happened was patients who had ochriplasmin had higher rates of success. And even patients with macular hole less than 250 microns, which unfortunately is very less in our country. Most of the macular holes are 600, 800 microns or above. So, but in ochriplasmin, what they found was those who had less than 250 microns had a higher percentage of hole closure, but if they were more than 250, it was not very significant. The other thing you must remember is whenever you separate the hyaloid from the retina, there is always a risk of retinal tear and retinal detachment. This is one case where it is showing the vitreomacular separation at day 7 after ochriplasmin injection. And this is one patient who had less than 250 microns of macular hole. There is closure of macular hole by, in fact, day 5 itself, it had started closing. There is vitreomacular separation. It had started to close completely. So the potential uses are that there can be, in case of vitreomacular traction, ERM, macular hole. If you want to do a control PVD, there is a high myope or patient with lattice. You don't want the patient to be left alone, that whenever there is flashes or floaters, you come back to me. So you can have a control PVD setting in that patient, have with close follow-up. You can also have in some case of PDR, because PVD can help in DME and PDR also, or prior to surgery where PVD induction is difficult. In some cases, you can inject these cases also. So thank you for your kind attention.